You're in business.
Okay. So I have to say thank you so much for coming on. I was like, oh, all this snow, there's going to be no one coming out tonight. I'm going to be talking to, Murray. We're just going to have a coffee. Yeah, have a coffee, have a visit, and then that would be it. So thanks so much for venturing out. So Murray and I didn't realize it was 13 years ago. Okay, so that's, so we met when I was still helping out at the urology center. And I can't actually say how things are at there right now in terms of physiotherapy. Has anybody been there recently? Is there a pre-op physio happening over there? Does anybody know? Yeah, I don't know. It kind of fluctuates because the physiotherapists who staff the urology, for the prostate.
Not me, a friend of mine. Yeah,
okay, good. Good, yeah. And so, but I'm not sure, at the time when I was there, we provided a fair amount of post-op care as well. And I'm not sure if that's happening because the physios at St. Paul's are they're being pulled from inpatient, physio, and then they kind of do a little bit of the prostate stuff. But anyway, so I have been practicing, I've been working in pelvic health for about 20 years. I used to work with the health authority, which is why I was at St. Paul's. And in the last few years, probably, 7 or 8 years, I've moved into private practice, and I've got my own practice now called Prairie Pelvic Health. And that's all I do is pelvis. Here to here, that's kind of my jam. And I would say probably about 30%, 30 to 40, I haven't actually counted, but I'd say fair 30% of my clients are male. So a decent amount if we think about pelvic health. Interestingly, not very many men come through with prostatectomies these days. So most of my clients currently are more with pelvic pain. So I would say guys between 30 and maybe 50 or 60 with penile pain, testicular pain, difficulty emptying their bladders and things like that. So that's probably, I would say. So I feel like there's men out there who have had, who are living with prostate cancer, have had radiation, or are on androgen deprivation therapy, or of course, prostatectomies, who are living, I don't know how things are being treated for you guys. So anyway, I was thinking that I kind of would I would get to maybe find out a little bit about you, but there's more than I had thought. So I'm going to switch, which is fantastic. So maybe I'm going to ask if you could kind of go through at least maybe kind of, anybody been diagnosed with prostate cancer in the last year? 2, okay, thank you. Okay, and then the last 5 years. Okay, and then last 10 years, there's a few, okay. And then over 10, so we've got 3. Okay, all right. So, so some of you, you've been living with prostate cancer, or maybe are in remission, or wherever you're at with that for, some of you for a long time. So I feel like, maybe this information isn't going to be, that valuable for you. I'm not sure, but can you tell me, maybe we can start to talk about different, Murray mentioned incontinence, different side effects from your cancer treatments.
Tiredness.
Fatigue, okay? Yeah.
I had prostate removed a little over 2 years ago.
Okay.
I've been incontinent ever since. In the beginning, I was wearing 40 pence about a day. Right now, I'm on 2.
Okay.
Sometimes only 1.
Okay. Okay. So we've talked about fatigue. We've talked about incontinence and moving from 4 depends a day to between 2 and 1. Okay. Anything else? Anybody else have some?
I couldn't pee.
Okay.
Yeah, I was continent.
You were too continent. Yeah. Okay. So not able to pee. Yeah. Okay. And so how is that? Is that still a problem, or is that something? So that was kind of just initially post-op, or?
Yeah, right. Yeah,
okay.
Right after the radiation.
Oh, after the radiation. Okay. Okay. Anybody else have some side effects that they want to talk about? Yeah.
Radiation burns to my colon, so they say I have radiation colitis.
Okay, so radiation burns to the colon, radiation colitis. So, so that's probably like really loose stool. Is it hard to control the stool? Yeah, okay, so are you having to wear pads because of that? Is that?
No,
No.
I haven't
Okay,
to do that yet.
okay, so, yeah, okay, what else? Ernie?
I had brachytherapy, and I had a bit of incontinence about 10 years after.
Okay,
And I visited you.
yeah,
And well, it's pretty well not materialized anymore. It's
Okay.
incontinent now,
okay,
except I've stopped drinking a lot of coffee.
yeah.
That was
A big thing, yeah, okay. Yeah, so so just to repeat for the folks who are listening to the recording, that was brachytherapy and then about 10 years afterwards, some incontinence, and then, you know, decreased the coffee drinking. Ernie came to visit me, and then now he's feeling well and not having leakage. Okay. Anybody else? Yeah.
So do you think the coffee is related?
Yeah, that's a great question. Is coffee related to the incontinence? And for sure, lots of people have that issue. Not everybody, but coffee is a stimulant. And so if we think about, you know, why do I drink it in the morning? It kind of gives me, like, it wakes me up a little bit. Some people drink coffee because it gets their bowels moving. So they have their first morning coffee and then they're off to the bathroom and, you know, they're happy and they're like kind of empty for the day, right? But that's because it's a stimulant. And so it can also do that to the bladder. So it can stimulate the bladder and make it kind of spasm. And so that can give us more urgency, and so that difficulty, like, oh my gosh, I got to really go to the bathroom right now, and then leakage with that. But also, interestingly, and I don't know exactly the mechanism behind this, but it seems to make the stress incontinence worse for some people. So if the urgency and urge incontinence, so that's that really I have to pee, and then the stress incontinence is that cough, laugh, sneeze, lifting something heavy. It seems to somehow, for some people, make that leakage worse as well. So if anybody here is having any issues with that urgency, difficulty getting to the bathroom, or just kind of leaking for no reason at all, they're just like, that could be the bladder spasming. And so the first thing I would do is really minimize or get rid of the caffeine, at least for a little while, and see if that makes a difference, because that can be a really big player. Yeah.
I found that carbonated water is too.
Yes, yeah, carbonated water. So the kind of the classic things that irritate the bladder are caffeine would be number one for sure, carbonation, artificial sweeteners for some reason, spicy foods for some people, acidic stuff. So like, you know, if you put lemon in your water, or if you really like to eat oranges, for some people tomatoes for some reason can be really problematic. Alcohol, that's kind of a known, and nicotine for some people, just because nicotine is again a stimulant. And so it can cause, so those are kind of the list of the things, but yeah, carbonation for sure. So then I have people coming in. I had this one gentleman actually not that long ago, in his 50s, no issues with prostate cancer, but was coming in and he was soaking through his clothes, like he was just leaking so much. And basically all he was drinking was, I think it was Pepsi. That was basically all he was drinking. And I was like, dude, you know, that's, you know, we got to change that. And like, he was gobsmacked the next time he came back. Because he was willing to do it, which for most people, their caffeine habits are, but if you're leaving work because you're like wet your pants and you have to go home and change, like that's a pretty big motivator. And he was like, wow, I'm fine. And I was like, great, you're fine, go away. Like, yeah, go live your life. So yeah, so those basic things can be really, can make a really big difference. Yeah, yeah. Okay, any other like side effects that you want to talk? Yeah.
Just urgency.
Urgency.
You gotta go, you gotta go.
Gotta go, you gotta go, okay. And yeah, so that could be, again, kind of related to some of the things that you're taking in. So yeah, I would kind of take a look at some of the foods or drinks and just kind of see if that makes a difference. And yeah, sometimes that, that's kind of where we can start to use the pelvic floor sometimes to really try to manage that, and some different strategies around that. Okay, urgency. What else? Just hang on. Yeah, you go ahead.
So I have conditional leakage, if you want to call it that, at exertion only.
Okay.
If I go to the gym, I'll lift something
Sure.
heavy, then I leak.
That's the heavy lifting. So that's what we would call stress incontinence. Yeah.
Right, so
Yeah.
do you have any specific regimen for that type of leakage? Is that any indication that my abdominal cavity muscles are reasonably intact? I just gotta tighten them up a bit.
Right.
And since we're on that note, what do you offer at
Yeah.
your establishment?
Yeah, my establishment, my fancy establishment. Yeah, so the question was, I'm leaking when I'm lifting heavy things. I feel like my abdominal cavity is pretty much intact, but essentially kind of what's happening and what can I offer. So we have to think about our torso as like it's a canister, okay? Or like you could think about it as a tube of toothpaste, okay? So if I am lifting something heavy and or I'm coughing and I'm squishing, I'm doing some like pressure here. The tube of toothpaste, if you squeeze the middle of a tube of toothpaste, that pressure is going to go up and or down, right? And so if I don't have good support on the bottom end and I'm kind of squeezing through the middle, then I can be pushing down onto my bladder, which was okay before because I had my prostate below it or that sphincter that was really supporting below it and supporting the bladder, but now I don't, or it's shrunk or kind of whatever the type of treatment you've had. And so then now there's that pressure coming out. And so what we can do is we can, and maybe we'll do this in a little bit, but we can start to look at like, how am I breathing? How am I lifting something heavy? Because there's different ways to give you kind of stability through the abdominal wall. And then we can also look at the pelvic floor. So how's the pelvic floor working? Is the pelvic floor actually giving you support at all? Is it engaging? Is it working? Because we've got our pelvic floor, those muscles at the bottom, those are also called our Kegel muscles. We've got our diaphragm at the top and the abdominals and the back muscles. And those pelvic floor muscles should be coming in and supporting. And so we'll talk a little bit, remind me in a little bit about like what happens at what I offer or what physio offers, period. It doesn't have to be me, and what those appointments look like. But I think you had a side effect you wanted to mention.
Yeah, like, I'm not bothered by the urgency to go, but when I do go, after I think I voided, about 10 to 15 seconds later, there's maybe another 10 to 20 or 30 milliliters that, you gotta stand there and wait for it to
Right.
make its way down.
Okay. So that was, I'm not bothered by the urgency, but when I go to void, then what's happening is I void, and then 10 to 15 seconds later, there's more that comes out, and it's not just a drop. It sounds like kind of between 15 to 30 mils.
Yeah, it's not a cupful or anything like that.
Yeah, but it's also more than a drop or two.
Yeah.
Yeah, okay. Yeah, and so that, there's a variety of things that can be happening with that. So it could be that the bladder itself isn't squeezing very well, but it also could be that there's a potential like restriction at the urethra maybe, or that the pelvic floor could also be like almost not allowing you to empty properly. So there's a few different things that could be happening there. And do you prefer to sit or stand to empty? Like what's easier for you?
Well, I'm standing.
Standing's easier? Yeah, okay. So you feel like you get a better empty in standing as opposed to sitting?
Yeah, well, if I sit there, I'm here to do a puzzle, right? So.
Okay. So sometimes people like always empty their bladder in the same way because that's how they've done it. But sometimes like changing the position can make a difference in terms of like maybe you can relax a little bit better if you're seated on the toilet. Some people find sitting on the toilet, they just don't get enough pressure. Like, so it kind of varies, but if you're finding difficulties emptying in one way, try another for sure. Like, try the opposite and see if it helps. You know, that's probably an innate thing that people do, but I'm not sure, so I just wanted to bring that up. Any other side effects?
From the pelvic floor you're asking, or?
Anything. Nothing. You're good. Okay.
As far as the standing sitting thing, I do better when I sit because then I can relax my pelvic floor better.
Right. Yeah.
Um,
Yeah. Yeah.
Because I did have sort of a similar issue.
Okay. Yeah. 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 So that was a comment of somebody who just said that they preferred to. They actually found that they prefer to sit in order to empty because they are able to get relaxed better and get a better empty. So yeah. So playing around with that for sure. You know, it depends on kind of where you're at in life, but and what your function was before your treatment. But nobody's talking about sexual dysfunction either. And so that's like obviously another side effect that you know, there's things that we can do about as well.
They don't talk about that in this class. Only I do.
Okay, yeah, and so like, and that can be like, you know, and for those of you, I mean, lots of you have been living with this diagnosis for many years, but yeah, I know that like I talk to people who have been recently diagnosed and they're like, I don't care about sex. I just want to like treat this and be done with it. And if I don't have sex for the rest of my life, like, fine, that's totally fine. But then, yeah, then you get to be like, okay, now I've been through my treatment. Oh yeah, and now my bladder's actually working better and I'm feeling good and I want to get back to normal life. And then you're like, oh, and then now the sexual dysfunction kind of raises its big head and it's like, okay, well, and so there are some good, and maybe that was a bad word, a bad way to describe it, or a good way to describe it, I'm not sure. But that's something that can be potentially managed further down the road. So I think a lot of men think that, okay, well, if I didn't do anything right after I had my treatment, then that window has been lost. But with things like vacuum pumps and like if there's no function, like we can look at vacuum pumps, and there's some good research that actually shows that vacuum pumps can help to restore somewhat of the penis length if a penis has shortened over time because it's not being used. So there's some things that we can do there, and the pelvic floor is actually very involved in helping to maintain erections as well. And so that's something that we can work on, strengthen and learn kind of how to use the pelvic floor to keep that erection there too. So, yeah.
So what would you say the time, not the timeline, the timeline, you said after a while we could look at that. Like, is it 6 months after or
Well,
a year after?
Well, there is some research just with the vacuum pump, and like there's not a lot of research out there for men with ED, like further out from their prostate cancer treatments. I feel like, at least not that I've really come across. Like it's oftentimes that initial, okay, we're going to start with some injections or like whatever, but the one study with the vacuum pump was 2 years out, and that was looking at restoring length. But I still think it's worth giving a try, like further down the road, if that's something that a person is interested and motivated to do, because just like I cannot go to the gym for 20 years of my life and then decide I want to get fit and healthy, and I can start exercising and I can start, bringing more blood flow to my tissues, and, the same can happen with the pelvic floor and with the penis and with those, like that soft, the smooth muscle of the penis. We can start to see if we can bring some more blood to the area, help to start to slowly stretch the tissues as well.
The only problem with it though is that the longer you go without an erection, the longer you have no oxygenated blood going into the erectile tissue and it dies, it becomes scar tissue, and you're never going to stretch it and rejuvenate it, it's dead. And that's why you end up with a button penis. So my suggestion, and I'm 5 years removed, is that you should be using a pump right away.
Oh yeah, for sure. Like that's kind of,
Most men have 5 to 6 erections a night while
yeah,
they're sleeping.
exactly. Yeah, exactly.
So
Yeah.
it's oxygenated blood.
Yeah.
And we don't
Yeah.
know it. And all
Yeah.
of a sudden you go from that to sticking a needle once a week. That's not how you
Exactly.
do it.
Exactly. Yeah.
And so you have to stop that deterioration.
Absolutely.
And
Yeah.
that's for the vacuum pump. So right
Exactly.
away is when you should be doing it.
Oh, 100%. Yeah, I'm just kind of speaking. Yeah, I agree with you 100%. So the comments were that we should be, for men post-treatment, they should be starting with the vacuum pump right away. That that men, if erectile function is good prior to treatment, they're probably getting about 20 to 30 erections a week, nocturnal erections, so about 5 or 6 a night. And so that's kind of maintaining the length and keeping all the tissue healthy and oxygenated with good blood. And over time, it's really the tissue doesn't die because we don't want, but it does kind of scar up, or it fibroses, and so the earlier we can work on that, the better. And just doing injections once a week is kind of insufficient if we think about that. If we think about that 20 to 30 erections per week, then that one is not sufficient. So starting earlier, and I 100% agree. And that's kind of why I was asking, okay, who's in the room? Who's this many? This far out and this far out, because. That certainly, I think, is where the research is really going, and trying to be really proactive with that. And then also having something like Cialis or Viagra also, just to help initially, just first off, just to kind of also with the vacuum pump to help to bring some more relaxation into that area to promote blood flow. Not that it's going to help an erection, but it's going to help to keep the blood coming into the area as well. And so that's kind of like what a lot of the new research is looking at is kind of being really proactive with that stuff, even though a lot of gentlemen are like, nah, I don't really care, but then later they do care. So, yeah.
You pardon my ignorance here.
No.
What is the function of a pump?
Okay.
So it-
Yeah, so here's...
The vacuum stretches, and then once you remove the pump, do you maintain your erection?
No, yeah, so that's a great question. So the question is, how does a pump actually work? And so here's just one example. This is the Erectaid. And so basically what happens is the penis is inserted into the pump, and then the vacuum draws blood into the penis. And so what we're doing is we're starting to bring blood in, kind of hold that for a little bit, let it out, bring blood in. So we're exercising the tissues. And if anybody else has any other things they want to say about the pump, please speak up, because I'm not a penis owner. And so we start to kind of vacuum, we start to exercise it. But then what we can also do is then put this can be either used just to maintain the length of the penis, and so then it's going to function better when I have the injections. So that's one option, or the other option, is to then have a ring that's put. So it would be on the base of the or on the pump here, and then you would put that to the base of the penis to keep the blood in the penis for intercourse. So there's a couple of different ways that it can be worked. So you can think about this as an exerciser or a way to help to be used for actual penetrative sex or insertional sex. Yeah.
Thank you.
Yeah. Does anybody have anything else to add? Because like I said, I have limited experience with that.
Are you asking me if I've used
Well,
it?
you obviously have.
Well, you know what? Okay. Well, you haven't been here. I've talked about this, and people are tired of hearing this. And you are going to roll your eyes and shake your head. I know what you're going to do. I have an implant. I have a 3-piece penis implant.
Okay.
I tried the injections, they hurt. Not the Trimix drug burned. They adjusted the Trimix and it took a pleasure out of it. So I thought, I'm not injecting myself anymore, especially when I went through my urethra with the needle. That was it. None of that. So I went, the federal government said that they're paying for the cost of an implant now, it's $17,000.
Oosh.
But for men who had prostate cancer, they will pay for it. And so
Wow.
I talked to Nicole,
Yep.
Abby, and she said, by all means, go for it. So I went and saw my urologist, and it was one night stay overnight. I had no pain. Hydromorphone took care of that.
Yeah.
And it works like a darn.
Great. Awesome.
Absolutely works like a darn.
Awesome. Good. Good. Yeah. So somebody here is just commenting on that he had a small penis and it wasn't working. Is that what you mean by a beaner? Is that what you mean by a beaner? What does a beaner mean? Is that what you said? Beaner?
Oh, button penis.
Yeah.
Button
Yeah.
penis.
Yeah. Okay.
It was
Yeah.
hidden in that direction.
Yeah. So anyway, tried the injections and that really hurt with the Trimix, and so now has a penile implant that is being paid for people with prostate cancer by the federal government. Is that what you said? So their cost out of pocket would be $17,000, but that's been covered, and that the implant's working really well. So fantastic. Good. Good. Bionic. Hey, that's great. Yeah, that's good. Okay, so and there are different injection drugs that are available, and I don't know exactly what they're currently offering through the urology center, but there are some that do can cause some aching and burning right off the bat, and then there are other ones that typically don't. So if you've got one that you've tried or you've tried it once and it really hurt, you could always go back and ask for other ones.
It's expensive too.
Yeah.
So I think it was $110 and it lasted 2 weeks.
Yeah. Okay. Yeah.
What's that for?
The medication.
The
They make it at
the
Medical
injection.
Arts. Medical Arts is
Yeah.
a laboratory pharmacy that makes compounds. It's compounding pharmacy, so they make drugs there. So they put the 3 drugs together called Trimix for you, and then they can adjust the ratio of each of these drugs. Well, they adjusted it once for me, and it's still just
It didn't work. Yeah. Okay. Yeah. And then and everybody's different, and yeah. Okay. So
I got something bad.
yeah.
If you've had your prostate removed, the orgasm isn't not nearly the same
No.
after.
Yeah.
It's not hardly worth it. To some, anyway.
well,
Yeah.
I disagree.
Yeah.
Yeah.
Yeah, no, it can change it for sure, and especially it's going to be it's that's going to be dry ejaculate, or there's not going to be ejaculate, and so for some people that's a big part of their sexual experience. For others, not so much. But yeah, definitely it can change the orgasm after you've had your prostate removed 100%. Yeah, and that can be disconcerting for sure. Yeah, so. Other ways that we can think about that oftentimes, and this may be taboo, but I will bring it up because I think it's important, is that is to explore other parts of the body. So the anal sphincter, so at the anus there are a lot of sensory, oh my gosh, what's the word? Yeah, nerves. That's not what I was looking for. But looking for pleasure in other places. So playing at the anal sphincter can be very pleasurable as well, and can really feel nice for anybody, male or females. But anyway, that's a place where I feel like a lot of men we don't really talk about, and are maybe not comfortable thinking about that. But that's something to also consider too. So. Okay, so anybody worried about their bone health? Anybody on androgen deprivation therapy?
I was for a year and a half.
Okay, couple, yeah. So not too many. Yeah?
Those two,
Yeah, okay,
Yeah.
Okay.
9 months.
9 months, okay. Okay, so, yeah, so I mean, like if you're on the ADT for a period of time, we can start to worry about muscle mass loss and bone health and those kinds of things. Is that a concern for anybody in the room at all? Really, like, not really? Too late.
It was more that I went into menopause.
Yeah.
I had no testosterone.
Yeah.
And so I had insomnia, I had sweats, I had moods, and
Yeah.
I tried suicide 3 times.
Oh, I'm sorry. Okay, yeah. Yeah, so it's a rapid change and okay, yeah. So mood swings, sweats, loss of sleep, and obviously mental health challenges as well. Which whenever we take something away, any kind of hormone right away, whether it's for women with if they have surgical induced menopause, or men taking away your testosterone all at once, your body has not acclimated. And so the same thing can happen for women when it's that rapid, and it can even with going through regular menopause for some women. But yeah, it's that can be, I'm sorry to hear that was so challenging for you.
My wife catched me a few times. So.
Okay, well that's good. Good thing you're married. Okay, so what I was going to talk about was just like, your question was, what happens what do I do as a pelvic health physio? So for people who have been to pelvic health physio, like maybe you could throw out some of your experiences.
Success.
What happens in the appointment?
What happens in the appointments? I'm trying to remember.
You park your ego at the door, probably.
You park your ego at the door for sure, yeah.
Park ego at the door, okay.
I remember a rectal exam and you doing, or me having to Kegel.
Okay.
And try to count, and you could tell me how hard I was, whether it was very, I'm struggling for words.
That's
whether
okay.
it was squeezing very well or
Okay.
or
Yeah,
not.
okay.
I remember that.
Okay, so rectal exam, doing some pelvic floor or Kegel exercises, yeah.
And talking me through how the exercises are done properly.
Okay, and how are the exercises are done properly? Okay. Anybody else have anything to add?
Trying to connect to the muscles to get them to actually work.
Okay,
That was
yeah. Connecting to the muscles, yeah, because you know what? Your pelvic floor, when you have a prostate, your pelvic floor is still working. It's still doing its job. It's got lots of, it's helping you with your bowel and bladder and sexual function and some core stability. But like, generally we don't think about our pelvic floors until we have to think about our pelvic floors. And for men, women oftentimes because we're pregnant, having babies, we have a vaginal opening, so that's an extra opening in the pelvis through which there's like a loss of pressure and those kinds of things. So, but for men, oftentimes that's very hard, yeah, to kind of like, what are you even talking about right now? Like, what is the pelvic floor, right? Yeah, so that connection of like really trying to figure out where we're talking about can be a big a challenge, yeah. Anybody else have anything to say?
Before I had surgery, Nicole Babby told me to start Kegels.
Uh-huh, yeah.
And told me how to do it, and I think I was pretty successful. I mean, I would do 100 a day, and I could hold them for about 30 seconds.
Okay, okay.
And they helped a lot.
Okay, so yeah, so some people have success with being verbally given instructions, and that can be successful. Certainly in the female population, I would say the research says half of the female population, and I don't think the research has been done on men, but half of women are performing those exercises correctly when they're just given verbal instructions. So that means that half are, which is great. And so probably, maybe it's similar with men, I honestly don't know. But there are times where, okay, that might not be working. And so like that would be a great situation where I've got some instructions, I could give it a try. But then if things don't work, then that's a good time to go and like look for help, to say like, okay, I've been trying this, I'm not sure if I'm doing it right, can you help me out here? Because that can make a big difference. So Yeah, so when somebody comes into my office, first of all, I send you a big, long questionnaire asking you all kinds of stuff, and people don't really, they fill it out. Sometimes they curse me, but it's good information. And so we go through that information. So we talk about bladder function, we talk about bowel function, we talk about sexual function, and just kind of past medical, history and stuff like that, so I can get a good sense of where you're coming from. And then we move on to some kind of exam. So oftentimes it is a rectal exam to Murray's point, because I want to feel what's happening with the pelvic floor. I'm just gonna grab my model here. So, hey, if by the end of the night, if we could name this guy, that would be really great, because I don't have a name for him, and I keep pulling him out, and I say, well, this is my model. What's that?
That's easy, just call him Dick.
Dick. Edgar? Dick. Here's my friend Dick. Anyway, so here's the right bum cheek here. So I'm sure you guys have all seen this model a million times. You go and visit Karen and Nicole, and they probably pull this out or something like this. No? Okay. Well, we can come and look at it a little bit closer afterwards. But so here we have, that's the spine. There's the sacrum. That's that triangular bone at the base of the spine, and then we have our tailbone. Here's the rectum and the anus. So rectum and anus, bladder, prostate for in a healthy individual, the urethra. And this line here, it's kind of hard to see, but there is a line of muscle there underneath the prostate. That is the pelvic floor. Now that doesn't really do it justice, because it looks very skinny and non-existent there really. But if you look top down into the pelvis, it is literally the floor of the pelvis. So it runs from the front to the back, side to side. It literally is my floor, okay? That's why it's called the pelvic floor. And its job is to support our organs, to help us with our bowel and bladder function. And the only way in a penis owner that I can assess that properly is by doing a rectal exam. Okay, so in a vagina owner, there are 2 access points, but in a penis owner, there's only 1 access point. So that's what I do. So I can really get a sense of the function, because I want to see what those muscles are doing, but then I also want to feel what's happening with those abdominal muscles, because we talked about that toothpaste analogy earlier, right? So if I'm doing a lot of squeezing from up top and not much is happening down below, then there's a net pressure going down, right? So I want to make sure that the pelvic floor is working, and that the abdominals are not adding extra pressure down. So that's what we do. I do some assessments in standing as well, just kind of figuring out because this is all nice and comfortable lying down on the bed, but really we don't spend our days lying on the bed, right? That's not when I'm leaking. I'm not lying down and leaking. I'm leaking when I'm standing up and moving around. So doing some standing assessments can be really helpful as well. And then really looking at, like I said, what's happening with the abdominal muscles. Because if I'm going to lift something heavy and I'm kind of pushing to lift that heavy thing, I'm just pushing that urine out. So sometimes we have to start to do some abdominal strengthening to make sure that we're kind of changing that strategy and getting strong through here, so I'm not pushing down. That's, kind of a quick, and I don't have to do rectal exams. It just gives me the best information. And most of you probably have had a million rectal exams done, and so one more may not be much of a problem. Yeah.
I've had so many, I'm even starting to enjoy them.
Okay, there we are.
Oh, no, I'm just kidding.
Yeah, and so. So I think that is basically, I also wanted to talk about one thing that as I was pointing that out. Let's just kind of take a look at how close the rectum is to the bladder. Okay? They're really good buddies. They're close neighbors. So if anybody is struggling with constipation, that is very likely going to make your bladder leakage worse. Okay? Because if there's stool sitting in there, it's going to be irritating the bladder, it might be leaning on the bladder, not allowing the bladder to fill properly, or just making the bladder annoyed because it can't kind of do its job. Okay, so if you have any issues with constipation and you're leaking, I would say we need to talk about that or try to figure that out, and how to make sure that the bowels are emptying regularly. Yeah, so.
Is that not where a lot of people self-medicate? You know, like do the X-Lax or?
Yeah, which is okay. Yeah, so like, I mean, I would recommend stool softeners if you are having issues. So you can have things like, you know, Metamucil it's just a fiber and it kind of helps things move along. I personally find it really gross because it's all like jelly and I don't really like that. Yeah, they have those in gummies. They have them in pill form. Yeah, so there's a few different options. I mean, ideally, we're getting our fiber really from our food, right? Like, ideally, we're eating lots of plants that are going to help our stool move along. But barring that, I would, yeah, so things like Metamucil, Restoralax is another one. I don't know if you've come across that. Anybody has had that, but it's you know, quite easy to take, and it's a stool softener. It helps to bring water into the bowels to help to move that along. What we don't want to have is something that's a bowel stimulant, like Senecot or things like that. Like that, you should use rarely. Like it shouldn't for occasional problems with constipation. But like something like Metamucil or Restoralax, you could use that on a daily basis very safely. So really what we want is easy to pass bowel movements every day. You're not having to bear down, all that kind of stuff. But that can have a really big impact on your bladder function too. And same in women as well. So I like, you know, if women are talking about problems with their bladders, you know, I definitely want to know what's happening with their bowels as well. So, yeah. Actually, I saw this recent. It wasn't an X-ray. I think it must have been an MRI. But anyway, this guy was complaining. They thought maybe he had like an enlarged prostate, but they couldn't figure it out anyway. And like his rectum was like that full of stool. And it's like, well, what do you think is causing the issue? Is it this tiny little prostate over here, or this massive hunk of stool that's like sitting in there? So, yeah, it can definitely cause issues. So, yeah. How are we doing? Yeah, I think that's probably.
Question.
Yeah.
After surgery, if it's, like, I started Keegling right after.
Yep.
And say 10 years down the road, 15 years down the road, can you revisit it, and would a person have any success?
So the question is, you know, started Keegling right after surgery, and that was successful, that went well, but 10 or 15 years later, is that going to be successful? And I would say definitely that, yeah, it should be, because if we think about over time, if we don't exercise our muscles, any muscle, they can start to waste away and not be as effective. And so if we're doing maintenance that whole time, I'm going to the gym 3 days a week and I've been doing that for 10 years, then great, I'm still kind of maintaining that strength. But if I went to the gym 10 years ago and then haven't been, is there going to be benefit for me going now? And I would say yes. We should be able to get more muscle growth, hypertrophy, better function. Yeah. So, yeah, that's a good question. Any other questions?
I've got a unique problem that I've never heard anybody have this before. If I sleep on my back, I have no sensation that I have to pee.
Mm-hmm.
It's like a nerve's being pinched or pressed. If I lie on my side, yeah. If I lie on my back, I end up peeing the bed. And
Okay.
I have no idea I'm even doing it. I wake up and go, oh crap,
Okay.
I was on my back.
Okay. Yeah, and yeah, so that's interesting. So do you have any issues with like sleep apnea or anything like that? No. Okay. Because certainly, like if so, sometimes that can happen. So the comment was, I lie on my back, I don't notice that my bladder's full, and if I lie on my side, I do notice and that's fine. But sometimes there ends up being peeing the bed because of lying on the back and not having that sensation. One thing to pay attention to is potential sleep apnea, and so that's where we're sleeping, and that oftentimes happens on our back, right, where I get the sleep apnea. So then I have long periods where I'm not breathing, and what that totally gets our nervous system like right wound up, and then that can cause leakage to happen. So that's one thing to be aware of. Where the nerves are in the bladder, they're like right at the base of the bladder, like the most sensitive, the most sensitive areas for filling. And so if we're on our back, we may not have that, those may not be stretched out enough to actually trigger that sensation for you.
I may have sustained some radiation, well, I did sustain radiation damage. I had 39 radiations.
Mm-hmm.
Mine was a stage 3 cancer, and it had attached itself to the bladder wall, so I didn't have a clear margin
Mm-hmm.
when they removed my prostate. About a year later, I'm peeing straight blood, and they went in and looked, and I had a big burn in my bladder wall
Okay.
where the radiation was. So now maybe it has damaged some nerves.
Yeah, that's a reasonable, like that could be happening as well. So just to comment that there was some radiation damage to the back wall of the bladder a year after the surgery or after the radiation that kind of showed up. And so maybe that could be, and that's definitely a possibility as well. Yeah, that could be just like physically some nerve damage there. Yeah, for sure. Yeah. Yeah. Okay. Yeah.
So how does the bladder sit in there? Like, or what shape is the bladder?
The bladder is kind of like a water balloon. Is kind of how it expands with filling, and then it's a muscle though. So if you can imagine, if I filled up a water balloon, it's just gonna, as it's filling, it just kind of stretches, and if I turn that water balloon upside down, and I just let it hang there, the water would eventually kind of dribble out, but it wouldn't rush out, okay? But if I squeeze that water balloon, now it's gonna rush out. And that's kind of what happens with the bladder is a muscle, so it'll relax and expand, but when I go to empty, the muscles are actually contracting and squeezing that urine out. Yeah.
So if Brian lays on his back there, like it's flattened right out kind of thing? Or if you go on your side there, then
It does, it will kind of change, like it will change its shape, yeah. Like it's not, like if we think about, what's a good example? Maybe the anus, maybe, for example, like it's a tube and it's always going to be a tube. It's not going to collapse on itself. It doesn't really change, well, it can change, like it can get stretched, but it's going to kind of stay in that same spot. But the bladder, like there is more flexibility to it. Yeah, yeah. It's a good question. Yeah.
How come I didn't get a good question?
I don't know if there's been a lot of questions. I feel like, yeah. I did want to mention a couple of resources that some people you may have come across already. There's a podcast. I don't know if you've ever heard. Does anybody listen to podcasts, by the way? A few, not a ton. Okay, maybe. I'm a sucker for podcasts. I just devour them. I nerd out on a lot of pelvic health podcasts actually. But anyway, there's this one called The Penis Project, and it's a sexual health therapist and a physiotherapist, both out of Australia. The first few episodes are terrible recording quality, just FYI. They're really hard to listen to, but they do get better. They interview people. They interview professionals, but they do a lot of interviewing of people with a lot of men with prostate cancer, but then they also have other people who they interview for a variety of different things, Peyronie's disease, there's a few different things. Anyway, so that's a good resource. And if you are interested in some information about vacuum pumps, there is another Australian resource. It's called A Touchy Subject, and that's a website. And the therapist on there, she kind of talks you through like using vacuum pumps, and that kind of, you have some videos and things like that that you can access, and a bit of a protocol around that as well if anybody's interested in that. So those are some things there. Any other questions? Yeah?
If you're getting radiation, the pelvic floor is obviously at the bottom.
Mm-hmm.
At the top, with the bladder, are there any muscles there, or is it only nerves and so forth? And can you reinvigorate that if you've got maybe some radiation damage?
Okay, so if I'm hearing the question correctly, so we've got the pelvic floor at the bottom, bladder is above that, and you're asking if there's muscles above the bladder. Is that what I'm hearing you ask?
Kegels for the bladder?
No, unfortunately, can we do Kegels for the bladder? No, because the bladder's not under our control, really. Like I can't voluntarily squeeze it. I can go and sit on the toilet, and then say, okay, it's time for me to pee, and then the nerves go and they actually contract the bladder. But I'm physically not, like, it's not like I'm doing a bicep curl, right? Like I can't do that. So that's under what's called the autonomic control. Just like my intestines or my heart, like those are things that I can't control either, unfortunately. And I wish there were, because I do have some clients who have just basically a bladder that's not functioning anymore, and then they're having to self-catheterize on a daily basis to empty the bladder, just because the bladder muscles basically stopped working for whatever reason. And it's a frustrating situation to be in. Yeah. Yeah, and with the radiation, like the bladder's not going to be able to stretch quite as much, and may not be able to contract like quite in the same way as well, like with that effects of radiation over time.
It was quite remarkable to see when he scoped my bladder to see why it was bleeding. And he showed me the one side, and he said, see the smoothness? And then all of a sudden he got to the radiation side, and it looked like a mountain range. It was all lumped.
Okay.
He said, this is where the radiation damaged your bladder on
Right.
the side. And then there was
The bleed there.
massive boil.
Yeah. Yeah, so the comment was just like with having a cystoscopy and looking inside the bladder, that normally the bladder lining is a nice smooth lining of the bladder, but on the side where there was radiation damage, it looked more kind of like a mountain range. It was really like lumpy and bumpy and not healthy looking. I think you had a question. Do you have a question or comment?
Well, just thinking about, to your point on the bladder and its elasticity and,
Yeah.
and its ability to be auto functioning, I guess. Could it not be, though, like any other muscle that we have in our body, we still have some control in maintaining that elasticity, regardless, I think, of radiation. I could be very wrong on this, but if you're ingesting enough fluid to maintain a fullness, we'll say, from whatever, that should, when you're lying on your back, you have no pressure down, so that would help maintain a volume, and then stand with your Kegels to make sure that you can retain that for whatever period of time that is before you absolutely have to release.
Right. Yeah. So the question is whether or not we can, if I'm hearing you correctly, can we have some of our own control over the elasticity of the bladder by making sure that it's like that we do allow it to fill, so that we can kind of maintain some of the stretch on the bladder, and then going at the kind of the last possible moment. Is that kind of what I'm hearing you say?
In a nutshell.
Yeah. So yes, to some degree. Like I would advise, and that's why, like, right after, if you've had a prostatectomy, you'll be told, like, you need to lie down in the afternoon, allow the bladder to fill, right? So we now need to allow that bladder to start to kind of do its job again. Sometimes that's why we use penile clamps as well. We didn't talk about clamps, but with the idea of, like, allowing the bladder to fill sometimes so it can start to do its job a bit better. So there is that to some degree. But the damage to the tissue, we can't not, like, I don't think, to my knowledge, and I could be mistaken because I haven't looked at the literature in this, but there is going to be some fibrosis and changes of the tissues with the radiation. And what we don't want to do is always hold the bladder at its fullness all the time, because just to what I was talking about some of my clients who are self-catheterizing because the bladder muscles aren't working anymore, we do risk that if we're really trying to hold it at its full capacity all the time. Those bladder muscles get too stretched out, and then they can't do their job of squishing. So it's a bit of a middle ground is kind of what I wanted to say. Does that answer your question or comment, or maybe not?
In a way.
In a way, okay. Okay, so can I do one thing? I remembered I wanted to do this before. So what I'd like everybody to do is do we have time?
Oh, yeah.
Yeah, we're okay?
Oh, yeah.
Okay, so I'd like everybody to stand up, and you're gonna put your hands on your abdomen. And I want everybody to just take a nice big breath in. And as you breathe in, I just want you to observe what's happening with your abdomen when you're breathing in, okay? So we're gonna take that nice big breath in. Okay, and then blow that air out. Okay, so on this next one, what we're going to do is we're going to try and tighten our pelvic floor. So if you're not exactly sure what that means, we can think about trying to draw the base of the penis towards you. You can think about trying to stop your urine flow, but something like try to do that on the next exhale. So we're going to breathe in and just relax again. Okay, and then I want you to tighten in your pelvic floor and then hold that as you exhale. Okay, try that one more time just so you get a good sense of what's happening. And then we'll sit down and I want to get a little bit of feedback about that. Okay, all right, sit down, and then I want to hear some kind of experiences about what was happening with that, with the lower abdomen. Okay, so your butt cheeks were squeezing? Okay. Is that going to help your bladder?
Help your butt, not your bladder.
Well, probably not. But that's interesting, right? What was happening with your abdominal wall, like when your hands were when you were squeezing? Did you get a... They're just rock solid. Yeah, rock solid. All right. Okay, anybody else? Yeah. Didn't move. Nothing happened here? Okay. Didn't go out, didn't go in? Okay. Anybody else?
My pelvic wall flexed.
I rocked in a little bit.
Yours kind of went in a little bit? A few went in? Anybody go out? Anybody kind of get a bit of a push out? Like, did they notice that their hands were getting pushed away from their... Okay.
Like when drawing air in.
Sure. But on the squeeze and the exhale, is that where you found kind of that push out? Okay. Anybody else have that feeling? Okay. Yeah, and so that is one way. So what I would suggest, like, I don't know if you're having any bladder issues, but that if we are doing an effort like a cough or a sneeze, to, like you were talking about the heavy lifting, and I'm trying to squeeze but I'm pushing out, that's going to be putting more pressure down onto my bladder and actually pushing the urine out as opposed to lifting it up. Yeah.
When you were breathing or wanting this to breathe, were you talking chest breath or diaphragm breathing?
Oh, I didn't get super specific.
You didn't get that.
Yeah.
That's what I was trying to do, is
Okay, and so what were you noticing with that when you were doing that? When you were kind of doing that diaphragmatic breath?
It was a little more difficult to do than to bring inhale into your chest.
Yeah,
It was
yeah.
more difficult.
Okay, yeah. So, yeah, and so we can kind of look at if we're doing a lot of kind of breathing with our bellies. It's not necessarily a bad thing, but that can also be putting more pressure on the bladder. But also, if I'm just breathing just up here, then I might not be getting that kind of full deep breath that we need, and that can affect some of my pelvic floor function actually in a roundabout way, but that's more than we need to get into tonight. So anyway, any other kind of final questions?
Do you hear from your clients if it's going to help out if they consciously do the Kegel as they are doing some strainings?
Yeah, absolutely. So the question is it helpful for us to do a Kegel when we're doing some kind of strain? And so that could be heavy lifting, that could be a cough or a sneeze or whatever. And I would say absolutely. That can be super helpful, especially, again, kind of in men whose pelvic floors haven't necessarily been having to work, haven't been having to do that job a lot of the life, or they haven't, or not as hard. So that can be really helpful to support the bladder and close off that urethra. Yeah. So that's a great idea as well. Yeah.
So if you have really loose bowels and you go and lift something heavy and you poop your pants.
Yeah.
For lack of a better word.
Yeah. Let's be honest. Yeah.
Yeah. Or you dribble.
Yeah.
Is Kegel going to help that?
Yeah, so the question is, if I go to lift something heavy and I've got loose bowels and I poop my pants or I dribble some urine, our Kegel's going to help with that. Possibly, but we also have to look at how you're lifting, right? Because if I'm lifting and I'm going to back up so maybe you can see me in the camera, I'm not sure, but like if I'm lifting something up and I'm kind of pushing out my abdomen to give me that stability to do that, I'm forcing pressure down onto my bladder and onto my pelvic floor. And so we may have to redo or kind of relearn how we're doing some of those heavier tasks and maybe build some strength around that. And even though you tell me that you've got the six-pack abs, we may need to build some strength. We may need to build some strength there. And so definitely that can be helpful, and with learning with that, yeah.
So, I don't have a problem, but I don't understand the Kegel. So it's wide open unless you hold it. So does that have to hold it all day long so you don't pee yourself? I don't understand that.
Right, so the question is, do I have to hold my Kegel muscles tight
How do you,
all day long?
When you pee, normally, you let it go.
Yeah.
So this Kegel, you have to turn it on, like you're saying you turn it on, but does it stay on all the time, or then you release it, or how does it work?
Right.
How does it know?
Yeah. That's a good question. So what we want to do when we're strengthening those muscles is a lot of what we're trying to do is we're trying to teach those muscles when they should be working and when they shouldn't be. I'm not walking around with my pelvic floor sucked in all day long. Okay.
That's what I was wondering.
Yeah.
So
Yeah.
you don't pee. If you don't have a sphincter right where it's supposed to be.
Right. And so what? Yeah. So the
That's
question.
my dumb question.
Yeah. No, it's not a dumb question. It's a great question. The question is, why am I not peeing with that?
Yeah.
Yeah. And so part of the urination process is like I talked about is also that contraction of the bladder.
And you dribble
Right.
all the time.
So there can be some dribbling that's happening. Yeah. And so that's sometimes why, I have a client who I've been working with. We did a really, he worked his butt off, and we could not make gains, and we did a little bit, but then we kind of got, and I think just because his urethral sphincter was just damaged enough that there was that dribbling that was happening all the time.
Well, that happens normally, because that's why you have to kind of shake it out, because it's that, because
pelvic floor, I guess it would be, I don't understand how you just, because it keeps on, like, working all the time.
Yeah, and so some of it, it's not completely engaged all the time. It has a little bit of tone that's kind of sitting there. So it's sitting like, so I like to think of the pelvic floor as kind of like an elevator, okay? So when I'm walking around, I'm just walking around, or I'm standing in line at the grocery store, I'm on the ground floor, okay? That's where my pelvic floor is. If I go to lift my grocery bags, let's say this. If I've got a full bladder, maybe my pelvic floor has now gone up to the first floor, okay? If I am lifting something really heavy, it may go up to the second floor to kind of give me good support. But then it should come back down. When I'm not doing something hard, it should come back down to the ground floor. When I am peeing, it's in the basement. So there's extra relaxation that happens when I'm on the toilet.
Yeah, that's controlled by your mind. Like,
Correct. Yeah.
When they take out your prostate, they remove one of your
yeah, I know.
sphincters.
Right above it. Yeah, I know.
But you have a sphincter still at the end of your bladder. That's what's stopping you from peeing.
Okay.
It's not your Kegel.
Okay.
So when you start peeing and you flex your Kegel, it stops you from peeing. So it's not holding the pee, that sphincter is what's holding the pee.
Then I don't understand then how come, I had radiation, I didn't have this, and
Yeah.
I had other problems. I had, the opposite, but I don't understand that. I'll have to figure it out
Okay.
myself.
Yeah, and so the comment was that the internal sphincter at the base of the bladder is keeping the urine in as well. And there are men.
Why isn't it working? If you remove the prostate, that sphincter has to be gone.
Well, in an ideal world, it is that one right at the base of.
Actually, they do remove that one sphincter, and they do a prostatectomy, so I don't understand this.
Yeah.
I'll talk.
Okay.
I just don't understand.
Okay.
When he scoped mine, I saw him going up the urethra, and he got to the bladder, and my sphincter's there. Even though because your prostate is a little bit below your sphincter, there's still some space there. So you've got two sphincters, one in your prostate, one at your bladder.
Yeah.
So when I don't have my prostate anymore, so when he went up, all of a sudden there was my sphincter, it went into my bladder. So they don't take that sphincter out.
Well, ideally, sometimes they. Ideally, sometimes they do. Yeah.
When they took my prostate out, my sphincter was damaged. They
Yeah.
cut it hard, and that's why.
Yeah. Yeah. So that internal sphincter can definitely be damaged because they have to get all the cancer cells. Yeah. So because the prostate can really kind of grow up, right? So yeah. Anyway. Okay. Okay. One more question.
Two if I may.
Okay, two. You may.
I'm a little bit different than a lot of people in the room in the sense that I haven't begun my treatment yet. Next Thursday, I'll go for my first of 20 EBRT
Okay.
sessions.
Okay.
So the first question is to yourself.
Yeah.
Is there any benefit in trying to learn Kegel in my circumstance before, or am I better off to kind of go through the stuff and see where I'm at after and deal with it then?
Okay. So the
I'll
question.
ask that question of you, and then I'll ask one of the.
Sure. Yeah. So the first question is, I'm going for EBRT next week. Is there any benefit for me learning how to do Kegels right now? I think you said you're having 20 sessions, in your situation, because there's not going to be that that immediate pre and post, right? And the removal of the prostate. I don't see it necessary to kind of rush with that, but it is something to probably, it would be valuable to check in on, after your therapy and how you're feeling, and just to kind of understand what's happening with the pelvic floor and things that you could maybe do to maintain over time. But it's not a big rush. Yeah.
And
Yeah.
the collective experience in the room, I would value any input in terms of something I should be doing either before or during the treatments for those of you who had EBRT. Is there any
Make
tips?
sure you have a full bladder.
Yeah, I think you have a full bladder.
All right.
Get a clap if you have.
Only takes 7 minutes, the radiation. Lie there and it spins around you and you don't feel anything.